Good morning. Welcome to HIMSS 2017. It's my pleasure to welcome you to the Ascom booth and also have the distinct pleasure of introducing Dr. Rueben Devlin, who will be sharing his vision of how to create and how he created the first digital hospital in North America. His vision over the course of several years has come to fruition. And we're very fortunate to have partnered with Humber River Hospital and having Dr. Devlin spend a few minutes talking about the process, the vision, and ultimately how to execute. So, Dr. Devlin.
Thanks very much, Tim, and good morning, everyone. And Tim says, well, it was an idea of a team, and I'm pleased to have members of the team, the current CEO, Barb Collins, Kevin Fernandez, our CTO, Othman Khan, one of our critical technicians at the hospital, and later on Peter Bach, who's the CIO. So it's a team sport. CEOs come up with all these great ideas, but if you don't have a team behind you to make it happen, that's all it is an idea. And so years ago, we started to have the opportunity of looking at our facilities. And what we had were three old facilities. I became the CEO of Humber River in 1999. And it became a merger of three facilities in 1997. So it was three community hospitals, the oldest one being 1949, and the newest wing was in 1975. So you can see the challenge of trying to bring old facilities up to date, and it's important that you recognize what the challenge was. So in 2002, and I put this down, we started to talk about where was healthcare going, and to start the journey of where we're going. So we developed a vision for our facility, and it was a hub and spoke model of healthcare, with services by a variety of providers, with an ambulatory center and acute care hospital for episodic treatment. And all providers would be linked electronically to the state-of-the-art facility. And I put the date there because I think it's critical. So it's sort of an old vision, but the ideas haven't changed much since. The vision stays the same. And I will tell you that many of the things that we talked about then did not have any technology to back up those ideas. And we talked about 4 levels of integrated care. Primary care connection. Primary care is key to what we do. Partnerships with other providers, such as long-term care facilities. Secondary level institutional care, which is ambulatory care. And those need to succeed for your critical and acute care facility to work. So the most episodic treatment, the most critical patients in an acute care facility. So in 2005, government approval to go ahead. We're in Canada, which has a socialized type of health care. Don't listen to the politicians here. We provide lots of excellent care. The model is one full-service acute care facility on a greenfield site, bringing together all levels of acute care to create the volumes for clinical excellence, and that's very important to us. And based on population growth, sustainable and efficiency challenges, increasing on interventional procedures, we saw that as the future, less intervention, a digitized era, and how, because your history is a community hospital, how do you make a large hospital feel small? And so New Humber River Hospital is large. We were going from a footprint on 3 facilities of 950,000 square feet to 1.8 million. Our catchment area is 850,000 people, 656 beds, just a number of emergency patients and newborns, just to show you that our volumes are quite large. We are in a large urban area with a diverse population. And then the challenge was how to deliver enhanced care in a bigger facility with more beds, increased patient visits, while doing so with a minimal increase in operating budget. So we're doubling our square footage. You might imagine that we weren't going to get a double operating budget, so they were not going to double that. And we created a value proposition. And most people, when they do a redevelopment, only look at the capital cost. And what we always ran in parallel was the operating plan compared to so CapEx and OpEx need to be looked at together. And frequently you see everybody's looking at just at the capital plan. Capital's once, operating forever. And so it was important that you look at the whole life or 30-year life of that project and try and map out what your costs would have been if you don't build new. The cost of new roofs, of new HVAC and all that. So you have to develop a plan, and it was important that it was a plan that fitted your outcomes, drives decisions both clinical and design. All levels of the organization need to be involved. You need to talk to the front lines. The frontline people are the people who do the work, and too often senior management decides to tell people how they're going to do their work instead of finding out how actually it happens. So that's critical to success, and having people enthused on that. You can't just write a PO for a digital hospital. You have to roll up your sleeves, get involved, and make sure that it's going to happen. Costs of healthcare are huge, and I said that capital's once, operating forever. And really this is a discussion about process redesign. It's all about process redesign, looking at your processes. What's the most efficient process, and what are the tools you're going to use to make it more efficient? Some of the solutions, as you'll see, are high-tech, some of them are low-tech, and some of them are old solutions with a little bit of a new twist. We developed 3 vision elements for the project: lean, green, and digital. And we thought that those were critical to what we were doing. Lean being efficient, green, obviously environmentally friendly, and I don't have to tell you about digital because you're the experts as well. Hospitals are challenged. So on the green component, hospitals are a big challenge to make sustainable. And they're open 24/7. We're always using a lot of energy. We anticipated a first-year utility budget of about $5.5 million. Recently, Ontario, the province of Ontario, has increased the rates, but this is the old business case. And if we reduce the annual utility bill by 40%, over 30 years, we could have saved close to $90 million. That's big money that goes back into healthcare. And there were a lot of different things that we used to look at, and all of the things which are not too sexy, but they're important in what you do to make it work. And so we're looking for a 40% decrease. So things like building orientation, dynamic glass, and that's an IT. So our dynamic glass changes according to the light outside, just like your sunglasses, but we can preset it, and the patients actually in their rooms can change the tint of the glass as well. Intelligent designs for HVAC, intelligent lighting design and control systems. 100% fresh air. So when we started to talk about that, they said 100% fresh air. Well, who thought it was a good idea to recirculate air in a hospital? And so we developed heat wheels that recaptured the heat and put it back into the facility and kept 100% fresh air. And world-class energy and water savings. Different green features, bicycles, water-efficient fixtures, low VOC, and a bit of connection to the natural world. So how do you make it a friendly place so that people didn't think they were in a hospital? So sitting areas, this area is outside of our emergency department. So if you have to wait for a family member and it's a nice day, then you can sit and wait for them. Little areas where you can go and eat, that's our piazza. We always said, how do you create design that brings people together? Where's the best place? It's always in the piazza, in the city center, town center. And we tried to create that. And out of that, we measured this, and it's important that you measure it. And this is just a graph of energy usages of hospitals in Ontario. And we're on the right, Humber River. That was our actual number. In comparison, there was energy usage metrics. And on the green area is where we're going. And you can see that we can be 50% better than other current facilities. And that's a lot of saved dollars that goes back into patient care. Okay. I think I'm having a little... The second element is lean. So in the current evolution of hospitals is we want to deliver high quality patient care cost effectively. So we need to maximize the use of our human resources. That's our biggest cost. It's about 73% between salary and benefits. That's our major cost. We want a clinical staff to focus on providing care. We need to minimize equipment redundancy, and we need to optimize inventory turnover. For some reason, that's oh, there it is. So the design obviously can be bigger, nicer, newer, but could have the risk of being less efficient. And this was just a study of that we did of how much time the nursing staff would spend with the patient. And you can see on direct care, 38%, on indirect care, 21%. But all the red areas were non-nursing care, where they were doing things that people would say that, well, those aren't nursing duties. And how can we get rid of some of those red areas and get them back taking care of patients? And we did a study with GE Hospital of the Future on our old facilities, and they tracked with the nurses and showed that the nurse was walking an average of 5.4 kilometers a day. And if we didn't do anything, if we didn't add technology or design changes, they'd be walking 11.6 kilometers a day. So that was untenable. And through design and technology that I'll talk to you about, we're actually able to reduce the 5.4 kilometers. We started our lean from the outside. So your average hospital that you go to, everybody walks through the front door, the same door, pandemonium in the foyer, and everybody looking to where they go. So our lean process started from the outside. Who has the biggest traffic of people throughout when they're moving people, and that was an airport. So we studied the airport, different industry. So that is supposed to look like an airport, and we have different portals where they go to, and that's the inside. So if you're dropping off somebody who has a disability, who can't walk very far, they're dropped off, they walk no further than 30 feet to their clinic, and it's less distance than in any of our old facilities. So that was an efficiency measure. And then, of course, you move on to digital. And some of the digital, I'm talking to the converted, but we'll talk about how it makes a difference. And it just had a discussion about it's not about the electronic record. Electronic record is important for us. It's part of the puzzle, but it's not the critical, because it's about information, communication, automation, and technology. And we needed a digital technology platform to drive efficiency. And then always the question comes up, what is a digital hospital? And so it's about patients and providers being connected at all times, having information at any time, anywhere, so that they can provide better care and better education to our patients. And this was an original slide that we did, in the early days. People, and I'm not going to talk to you about design, that's way out of my field, but as they explained to me, it was always point to point, and without an enterprise bus system, you could not create this, because I always call it an electronic roundabout, where the information gets on at one point and gets off at the right point, and it's made it possible, and that was critical to what we did. So it was important for our systems to be automated, systems and the tools used to enhance persons' ability to complete a task. Patient empowerment, it's their information, it's their health record, it's important that they have it. Workflows, and that was critical. Look at the workflows and make them better. And these are not toys for toys' sake. Everything that we bought, everything we put in had a business case. And as a CEO, we looked at 4 areas: quality, safety, efficiency, and customer service. And it had to fit into one of those boxes. And if it didn't, and if it fit into 2 of them, then it was really a plus. And many of you have probably seen this. The first rule of any technology used in business is automation applied to an efficient operation magnifies the efficiency. The second rule, automation applied to an inefficient operation magnifies the inefficiency. The automation started off with, and these are robots. They happen to be Swiss log robots and work very well. And risk this here. We'll just come over here if I can do this, and just on this one screen, you'll only see it on this screen here. And oh, that's the wrong way. Sorry, I'm not sure if it's going to work or not. Okay, but that was just a picture of the robot, and I'm going to forget about that one. I'll try and let it go. So the robots bring the supplies and the linens to the floor, but then we have to get rid of them. So you know we have a large footprint. So the slide on the left is from a hospital we built that we visited in Norway, and we keep that slide to remember what we did. But we put in simple garbage chutes. Well, garbage chutes for a 1.8 million building is not a small feat, and so that's the sort of design of where it goes, and it goes to shipping and receiving. And so it's 2. One, it's efficient, and secondly, it doesn't drag potentially infected material through your hospital. And just a picture of the system. And the second is tube system. We've had tube systems in hospitals for years. Most of the time they don't work. They're down, and we fought with them. But this one has been great. It's got a larger tube, and one of the additions is that each of these tubes has an RFID on them, and therefore we can track where they are if the system's down. The other thing is that all of our drugs, for the most part, are delivered by robot, except for narcotics. But because we can ID these, we'll be able to send narcotics through these as well, because it's locked out to somebody with a special code. And that's just a picture of the. That was just a picture of the. I'll go back. That's just a picture of the pneumatic tube. And electronic information, and that's what HIMSS is about, and we're not going to spend a lot of time on that. Next slide. So it's all about information being readily available, and that information is actionable, and all systems are IP based. We use Meditech, and it's worked well for us. We're not. It's not about who's better. You need an electronic system that makes it happen, and it needs to be integrated. We have on the right, you'll see sign monitors, physician order entry, bedside medication verification, and some of the mobile devices below where the nurses are using that device. Let's go back. Okay, we have a patient portal, and that's critical, so the patients can access their information wherever they are. If they're at home, if they're going to a new physician who's not on staff at Humber River, they can pull up the portal and see all of the information that they need. Room-side monitors are outside every inpatient room, and it gives a content. So if it's an isolation room, it says isolation. Because of all of our staff have an RFID badge, it'll say nurses in the room, doctors in the room, so that people don't come in. And it may say check at the desk. So there's a lot of information on the room-side monitor. Public status boards, the old whiteboards that were in hospitals, are now electronic, connected to the electronic system, and it's important that that information is there. And that's a picture of those in place. Just a digital. So you need to. The second component is that you need to be mobile and connected. And That's where Ascom comes in as part of the solution. If you have this is not an actual hand. So it gives us, we needed a rugged device. People in hospitals are brutal with their equipment, and we need rugged devices. So Ascom was willing to build something that was available and rugged. It goes to our nursing staff, to our code teams, our on-call physicians in-house, and to our porters, so that we can connect them directly. Nurse assist applications, cold call applications, alarm and alerts, critical call results, bed exit alerts. It has a camera and it has a barcode. And so at different times, a barcode scanner. At different times in the processes, we use all those. And one thing I'll say about, was not only about this, but about all the equipment, is it's important that you maximize the use of your technology, because frequently we're only using 25 to 35% of its capability. And this is just somebody using the Ascom phone. People use it for voice, texting, and so obviously our younger staff text all the time. That's all. My daughter doesn't pick up her phone, but she responds in 5 seconds to a text, and that's the real world. And emails. And one of the things that I think we talked with Fritz about 3 years ago, we said one of the things that were important was that when somebody's busy and understanding workflow, so everybody says pagers are out of date, but understanding the workflow in hospitals, you're sometimes juggling 3 balls and you're taking care of a sick patient and somebody's calling. You want to know immediately where that call's coming from, because you may just wait till later, or if it's an urgent code, then you might answer it. So having that ability to put the number on top tells the provider where that call is coming from, and it simplifies some of the workflows, and when we're taking care of patients, you need to know that. Rhythm strip, so if you're working in critical care and you have an abnormal rhythm strip, it shows up on your Ascom phone, so you can, if you're in another part of the hospital, you can start, if you're the physician, you can start giving orders if required, or you know what's going to happen. Codes, we try to keep the hospital quiet. I can't stand the overhead paging, and so our code team gets a special registration, and then if they get the code, they can acknowledge the code and go from there. That's all on the phone. Real-time locating systems, we use those for asset management. We use that in our employee and physician ID badges. We use it for the elderly, so that for the wandering patient, and we use it on our infants in the newborns so that they stay safe. And in fact, with our, and it's not this, not in this one, but in the RFID, if you put it on the newborns, when they take the newborn in the elevator won't work. And that was the RTLS, and I already talked about that. And locating staff and assets where they are. So if you need a porter to take some piece of equipment somewhere, you're able to find the closest person to that. The need to communicate, simple, to track with connecting the OR with connecting to the operating room and other operating rooms. So we can connect if we want to connect to our local trauma center, and we have somebody in the trauma room in the hospital, we can connect them. Communicating with unified communication. This is interesting. And if you're going to the operating room, each patient going to the operating gets an RFID. And then we ask them, who from your family, give us the cell phone of your family member or family members who you want to be notified where you are. It doesn't matter where you are. You could be in Los Angeles. Just give us the cell phone. So as you go through every step of that procedure, they get a text message. So they could be sitting in the waiting room. As I said, they could be in Los Angeles, and they could know where you are. So the biggest worry our families have is, oh, the procedure took so long. But usually what it is their procedure was delayed and there was nothing wrong. So by this, it settles them down from giving them the information, and they're asking our staff not so many questions, because we're keeping them informed, and that was critical to what we do. Patient empowerment is There's every inpatient bed has a bedside terminal, and on the nurse call button, when you press the nurse call button, it doesn't go to the clerk. It goes to the Ascom phone of your nurse for the day. So it's a direct connection for you to have a conversation with your nurse. And maybe, what would you like? You say, well, I'd like an analgesic. I'm making rounds now. I'll be there in 15 minutes. Is that okay? That's fine. And so that makes them, they don't feel like nobody's paying attention, so they can always connect directly. Go to the next one tonight. Sorry. And we'll go to the next one. I don't know if this is going to work again. We'll try it. No. Oh. Okay, so that's just an example of somebody using the bedside terminal. This is on the side. You can call it. You can check the weather. You can do nurse call. So you have nurse call buttons, educational areas for the patients, and so whatever they want for their disease, and so it's a lot of different things. You can pull up CTs, MRs on, and so you can show that to the patients as well. And so that's important for them to do. Two important workflows. One is the laboratory round trip workflow, and we've automated that completely so that it's ordered through physician order entry. It can be on your device, it could be on your Ascom phone, and then it goes through the automation of receiving the order. It's a bedside labeling procedure, so that the labels are created at the bedside after you've scanned the patient's armband, delivering the samples to the lab, and then once it's in the machine, it's untouched by human hands. And this is an example. And we store the blood that's received for 7 days, and in case we have to do a retest later on, then we don't have to take it from the patient again. So if we need other, and that's a critical thing for laboratory. Abnormal results have to be acknowledged. Normal results just go to the chart, and people acknowledge that. The second one is that's critical is the pharmacy round trip. Again, ordered by the physician. All of our drugs are wrapped with barcoding. They're delivered either by the robot, or else the narcotics are delivered by people currently. And then they're administered. So there's a scanner. So when you give a drug to a patient, you scan theirs, you open up the electronic record, you scan their card, their badge, you scan your badge, you scan the drug, and then you look on the screen. This drug was ordered for the patient. There's no allergies. It's the right time, and you chart it and you give it, and it says. And you can use the scanner on the Ascom phone. We have a number of places where there's scanners on the mobile card and on the Ascom phone. And that's just a picture of that. So in summary, we have a paperless inpatient record, patient portal, 75% automated delivery supplies, full building of automation, and the Ascom Myco Smart Handset, which streamlines communication, provides video rhythm strips, and helps in codes. And we have an RTLS system, fully automated pharmacy and laboratory systems. Next. And the benefits: higher quality, safety, efficiency, better customer service, focus on patient and family-centered care, and we've had a culture shift with improved morale for our staff and our patients. Next. Cost benefit, quickly. So 75% of our deliveries are automated. We've saved 165 kilometers per day of walking and 25 FTEs. And so it's not, nobody got let go because we would have needed more people, but we didn't have to hire those. So we needed to save money in order to provide better care, and that's one of the ways that we did it. Next. So how do you deliver enhanced care in a bigger facility with more beds while doing so with minimal increase in operating budget next? And so we've gone from 97,000 to 140,000 emergency patients. Our emergency departments were 21,000, now 49,000 square feet. But we've maintained our nurse ratio through the use of design and technology. Next. And let's see. We're 80% single patient rooms. I think it should be 100%, but that's the way the government went that time. And you can see that our units, our patient care units went from 11,000 to 28,000. And our nurse to patient ratio went from 5 in the old facility to 5.5 in the new. Next. So our next steps, we're not finished, we're just starting. And so that's what's exciting about what we're doing. And so this is what we really tried to do, is create a culture of innovation. People bringing new ideas, working with industry to make sure that we bring new ideas to healthcare, lean processes for all technology. We had super users. We're going to create a center of excellence at Humber River, black box technology in the operating rooms, and clinical monitoring command center. So one of the things the next project is a command center. Industry has command centers. We're going to create a clinical command center that monitors patients initially within the hospital and hopefully outside in the community. And I'm happy to talk to you. I've been able to talk to you about Humber River, and I'd be happy to take any questions you might have. Anybody have any questions? So the question was, we're not finished. But first of all, I think you need to have the mindset that how quickly technology changes and how quickly how you do things in healthcare change. The real push is minimal care within the hospital facility and pushing care out into the community. So how do we use devices out in the community to treat patients there and not have them institutionalized? What are we doing with big data to do predictive analysis on what's happened? So we have lots of data, but how is that going to help us to say, you know, we've got 1,000 patients who've had this problem. You've got signs that'll tell you that this is going to happen within 6 months, so we need to intervene ahead of time. So those are some of the things that we're looking at. There's some pretty exciting things to do. We don't want people in hospitals. We see them and the hospital needs to be part of the integration, and it helps keep the electronic record so people can access it. And that was the important piece of the patient portal, that the patient, no matter where the patient is in the world, they can access their information.
The 38% direct patient care time, was that before or after? And if so, what were the other numbers?
So the question was the 38%. That was before, and I know we haven't done that study yet as to when it was after. Anything else? Okay. Well, thank you very much. Have a great day.